actually tests all your clinical skills. As Vijay in the morning said, 7 clinical skills you are marked for, and apart from individual stations, you have to also pass all together when they sort of collect your marks and calculate. So all these 7 clinical skills all together for all the stations you have to pass. And this is a unique station where all these 7 skills are tested. So the chance of scoring and passing the exam is better if you can do this station well. Okay. So what are the skills that we test in session 5 and session 2? First of all, physical examination. That is the examination method. Okay. That is not the clinical findings you are picking up. How you examine a rheumatoid hand, how you examine a thyroid goiter. Remember, it can be an abdo case also, or a neuro case also, or a respiratory, or any other system. Or it can be a surrogate where they just come with an history and referral letter where you have to mainly focus on history. Examination may not find anything. Okay. So skill B is identifying physical signs. That is marked separately. So one is skill A, physical examination. Skill B is physical signs that you have elicited, and that is important for diagnosis. Remember, if you cannot get the signs right, your diagnosis will be wrong and you will fail the station. So this is very important, picking up physical signs for any station, not only station 5. But importantly, this also tests you other skills like skill C, which is clinical communication skills, that Dr. Nandini Vishwas just sort of discussed about. How you communicate with the patient, okay, show empathy, because see, these are mostly chronic conditions. Patients are coming with chronic conditions like rheumatoid, or like myasthenia, or like CKD on dialysis, or CKD doesn't want to go on dialysis, or waiting for transplant. So this kind of chronic conditions. So they will have lot of questions and lot of knowledge about the disease also, and they would have some concerns about the future as well. So communication is very important. Then of course, like any other station in clinical consultation, differential diagnosis. So what are the kind of problem patient has, what are the physical signs you have picked up, and then what is your diagnosis. So this combines history taking and physical examination, then arriving at diagnosis, then communicating your diagnosis to the patient and discussing treatment. See, it's almost like a normal clinical consultation you do in a OPD. 20 minutes time, as if a patient has come to visit your OPD, approaching that way. So I'll come to that, but apart from differential diagnosis, other skills tested are clinical judgment, definitely. How do you plan your investigation, management and treatment, and managing patients' concerns. Of course, as I said, they will have a lot of concerns because of chronic disease. And always in any PACES exam, patient welfare, how you maintain dignity, how you maintain patient comfort, don't give any pain, don't give any distress to the patient, don't be angry at the patient, whatever they say. Okay. So what is the approach? As I said, the approach is like OPD station. Okay, OPD patient. They come, start with an open question. Before entering the station, you will get a small scenario. Okay, they will give you a small scenario. So this patient is say 45-year-old man with hypertension and has history of chronic renal failure. Has come with shortness of breath. Please consult. Okay. So you get 5 minutes time before entering the station. Utilize that 5 minutes. Okay, like communication skill also you get 5 minutes time to read the station. So utilize this 5 minutes in planning okay, it's a CKD patient, what can be the possibilities? Maybe hypertensive heart failure, maybe anemia, maybe some pleural effusion, fluid overload, maybe that patient is having some other problem, cardiac problem or lung problem. So quickly think about the possibilities before you enter the station. Okay. Then when you enter the station, start with an open question. Sir, I am Dr. So-and-so. I understand you are Mr. Tandon or Mr. Smith. Your GP has or your doctor has referred you to me in this clinic, whatever nephrology clinic. I am one of the doctors here, or SHO, ST1, whatever the scenario is given, or house staff or RMO, whatever. And I am here to discuss your problem with you. May you start with telling me what is your main concern or main problem at this point of time. Start with an open question. He will say, yes sir, I am actually feeling, yes doctor, I am feeling shortness of breath. Then you go into quick history taking. Okay. Now the trick is that you have total 20 minutes. You have to divide this 20 minutes into history taking, examination, communication with the patient, and then answering question of the consultant, the examiner. So briefly, roughly 12 to 14 minutes you have to finish with the patient. So by 15 minutes examiner will be with you, and that 5 minutes is examiner's time. Before that they will not comment anything, they will not tell you anything, they will just sit and observe. At 14 minutes they will bell, at 15 minutes they will start asking questions, the examiner. So for the first half, 14 minutes or 12 to 15 minutes time, whatever time it takes, it's you and the patient. So start with history taking, open question, then go on a focused history, and then focused clinical examination. You don't need to examine the whole body. Whatever the problem is, the shortness of breath, you definitely have to examine the chest and the cardiovascular system. You have to check for edema. You have to ask for blood pressure. Then if they have any investigation report, you may ask for that. Trick is that if you see that the history taking is too long, patient, you have to manage the time. Patient is talking and talking and talking. You cannot be rude and stop them. But yes sir, I understand, I am coming to that. But I want to ask you another question. And build up your differentials by asking and excluding important points, negative and positive history. So apart from that, there is no restriction in starting examination while you are talking to the patient. Ideally history taking and then examination, but if you think that I need to examine the patient and then start maybe ask more questions, that is allowed. Okay. So suppose after examination you get a new finding and you want to ask the patient about it. Okay. So like you have examined the patient hands and all that, then you want to ask about patient's functional status, rheumatoid arthritis, how much it is bothering you, can you hold the pain, can you button and unbutton your shirt, can you do your activities of daily life, can you carry on, are you carrying on with your activities, how you are doing, and all those kind of questions. So that is going into the second half, like examination. Then again you can come back and take some questions, and then ask patient's concerns, then address patient's concerns. Don't forget to give a diagnosis, working diagnosis to the patient, and tell a plan by 15 minutes, 14 minutes, 15 minutes. Then the examiner will cross-examine you. Why did you come at that diagnosis? What investigation you do? What is needed and all that. Okay. So that is session 2 and session 5. So as I said, 20 minutes. You receive information before you enter. Utilize that 5 minutes time very well. You are allowed to make notes before you enter, and prepare and utilize that 5 minutes of time. And last 5 minutes, as I said, is for the examiner to ask you questions. So plan the session well so that you can do history taking, examination, as well as counseling, brief counseling in 15 minutes, and then last 5 minutes is examiners to cross-examine you. Okay. So actually it's a 20-minute session, but you and patient is 15 minutes. So you plan for 15 minutes. Next 5 minutes the examiner's time, you can't do anything about it. Okay? So I'm not going to detail, you all know about history taking, but practice a bit with your colleagues and whoever other candidates, if your friends or whoever is taking the exam as well, so that you don't miss those points. So presenting history, key questions, past history, drug history, family history, personal occupational history, social history, system specific history, if any, and of course the concerns, special concerns. Okay, so I'll end here saying that the preparation needs practice in small groups, as I said, and communication skill is also very important part of session 2 and 5. So practice it, think about, as Arindam was telling, mentally preparing for the exam, mentally preparing for the station, how I'm going to approach. Okay, this is 5 minutes, my history taking time is almost over, I have to start examining, otherwise I will not get time to address patient's concerns. While doing examination, you think that, oh, I've missed this to ask this question. Don't interrupt your examination, you carry on with the examination, but in between you can, ask questions again to the patient. That is allowed. Okay? Alright, so with that, we'll end today's morning session. We're running a bit late. So next what we'll do, we'll divide you into groups, 1 or 2 candidates per group, and we'll do practice communication skill and BCC, that session 2 and 5 in the first half, pre-lunch. Post-lunch, we'll go for clinical examination, where we'll have patients for 4 systems: abdomen, cardiovascular, respiratory and neuro. Okay? So then also divide as many groups as possible. We want to keep the examiner to candidate ratio at 1:2, if possible 1:1. Okay? So that you get good practice individually. Okay, so we have planned in that way. So let's not waste time, we go and move to our practice sessions. Okay? Any questions? Anybody has any questions? Anything you want to ask from morning session discussion? You can come back and ask later, no problem. During the practice session you can ask questions also to the examiners.